I'd like to welcome everybody to this first Disability and Social Inclusion seminar of the academic year, and to welcome Jim Blair. Jim has so many achievements and roles that I'm not going to go through them all, but he was the first person in the UK to be a consultant nurse of learning disability and acute care. He's Vice Chairman of the Special Olympics Committee of Great Britain. He gives advice to many organisations, including the Department of Health and the General Medical Council, on how professionals should treat people with learning disabilities. And he's, I believe, the only expert of the 12-strong advisory committee on NHS evidence. So I think probably that's enough to say about Jim to start. I should also say two other things, actually. We are recording this seminar. I hope that's okay with everybody. And secondly, we do have IT, but we've got some problems with it, and somebody is going to come in and look at it in a few minutes, but Jim is going to start with that.
The recording will be made available. Sorry, I'm actually a trainee journalist here, which is why I'm interested in how the recording will be made available.
I hope so, if it works properly.
Okay, and how will we get hold of that?
You'd have to email me.
Okay, and your...
Doria. Doria Pilling?
Joy.
Doria Pilling. You should have booked through me. Yeah?
Indeed, thank you.
Okay, thank you.
That's great. I'm pleased that you're here.
Jim.
And it's lovely to see everybody. What I'm going to do today is I'm really just going to have a chat with you about what I'm doing. Thank you, Doria, and thank you, Mike, for inviting me. It's great to be here, and it's good to be invited and to share some of the work that I'm doing with you and how you can help making things better for people with a learning disability. That's what the session's really about. I will explore how my role came to be. I'll explore why it's in existence, and I'll also be honest with you about why, sadly, I still remain the only consultant nurse for for learning, people with learning disabilities in acute hospitals in the UK, and I'll talk openly about what I think some of the pressures are around that. So anytime, just ask me questions. I'll answer them as openly and as honestly as I can, and throw whatever you like at me. And if you don't understand what I'm talking about, just say, Jim, I don't know what you're on about, and then I'll stop. What I'd like first, though, is for people to introduce themselves, so I kind of get a flavour of where you're all working, so I'll make sure I tailor examples to the areas that you're working in, so I can try and hit your needs as well as everyone else's.
I'm Claudia Brent-Menkap, and I work with some assistant trainers with a learning disability on training NHS staff, GPs, any NHS staff in learning disability awareness. Amongst other things.
I'm Louise. I'm a student here, a speech and language therapy student, postgraduate second year. But I used to work with NECAP also on the change picture by accessible information needs.
And it's nice that you're doing speech and language therapy here, because my wife trained here as a speech and language therapist.
Hi, I'm Major. I work with Student Counselling Service. I'm a counsellor and I work with other colleagues as part of the student mental health team.
Okay.
I'm Stephanie Linden. I work for a charity that provides advocacy services called Power, and we run a self-advocacy project in Hackney for people with learning disabilities.
I'm Gemma. I'm in Tower Hamlets Learning Disability Service.
And I'm Karen Christensen. I'm coming from Norway. I'm a researcher and a sociologist, and I'm here working currently on the project about migrant care workers. But I've done a study on this area of
Right. Lovely.
So I'm not specifically...
Do you come from Oslo?
No, I come from Berlin.
Right, well, I'm going to Oslo next week, actually, and I'll talk about it later. It's about you're launching the hospital passport in Norway and adopting some of the things that I've done at St George's National Conference, so I'm talking about it. So it's very nice to meet you.
I'm Alicia Mariah. I'm actually a GP, but I'm also doing the MA in Science Journalism here, so I'm kind of a dual patch. I'm really interested to find out more, I mean, I don't know enough about learning disabilities as a GP, never mind as a journalist, so really quite drawing in it.
Yeah. Well, very interesting. I had a phone call from a GP this morning. They didn't make one referral, made three for three separate people. So that's quite a key significance of how things are evolving and the change of what we're doing. So great if you ask some GP type questions.
In the organisational context, I know there's consultants, for example, in diabetes, are interested in the way that the whole system is very under-set up for people with learning disabilities. That's an organisation as well. That sounds interesting.
That's exactly what I was explaining about how my role was set up and why it's very similar to the medical consultant model. And that's exactly why it was built that way and constructed in that manner.
The acute clearance for friends with disability.
Thank you, nice to meet you.
I'm a listening and communication student, and I used to work as a teacher for hearing impaired disabilities people.
Nice to meet you.
I'm an educational discrimination lawyer with a particular interest in disability, and a partner in a training research consultancy called Disabilities, and we do lots of training within services about how law links to life, basically.
Yes. And the significance of the Mental Capacity Act. You might want to ask me some questions about that, particularly.
I'm much more an expert on the Equality Act.
Okay, great. You can ask me about that as well. You're probably more expert than I am, but I'll be happy to answer those questions.
I'm Aidan Warner. I work in communications at the General Medical Council. We're just getting ready to launch something that Jim has been providing a lot of help on, some online learning resources for doctors around learning disability. By coincidence, I'm also an MSc student here.
Great. Oh yeah, like you've got loads of spare time.
I'm Mike Floyd. I'm a colleague Dorian.
Nice to see you again.
Hi, I'm Kate. I'm another student, a speech and language therapy student here at City, doing my second year.
Good. Nice to meet you.
And obviously,
I know. Okay, so what do we know about the context that we're in at the moment? Well, as we sit here, people with a learning disability take their last breaths unnecessarily in hospitals up and down the country. Through the arrogance of health professionals, people are dying unnecessarily. Now, to start off by saying something like that, you could say, well, yes, Jim might say that, but does he just say that in a closed room that he's got a record on? I don't. I say that everywhere I go because it's actually the truth. It's a sad truth. It's a sad, stark reality of what's happening in hospitals up and down the country. Is it any one professional that's doing something horrendously wrong? No. Are professionals nasty to people with learning disabilities? I don't think so. I think a lot of it is a misunderstanding, misinterpretation, diagnostic overshadowing, which we'll talk about as well, and fear of getting things wrong, rather than actually doing things because they don't like people with a learning disability. I think that's one key thing to start off with. What other evidence have we got for people dying unnecessarily? Well, the confidential inquiry into the premature deaths of people with a learning disability, whose chief investigator is Matt Houghton, who's the chair of the Royal College of General Practitioners GPLD Council, has been doing for the last 18 months a study on this, and we know in these times where everything's getting cut, this has actually had its time extended. So the confidential inquiry into the premature deaths of people with learning disabilities, which is taking place in southwest of England, has uncovered quite a large number of issues and alarming themes that are being uncovered, as well as some good areas of practice, the details of which are not public knowledge just yet, but certainly thematically there is evidence to suggest that things could be an awful lot better than they are. At best, services are patchy, and at worst, they're an indictment to society. Who do you think said that? Somebody having a little rant? Somebody with any evidence? Or someone just sort of fancied popping it up and throwing it out into the wide ether? It was the most powerful person in the country for health. That is not Andrew Lansley.
CMO?
No.
Professor Mansell?
No. It's Anne Abrahams, small lady, who is the Parliamentary Health Service Ombudsman. Why is she more important than Lansley? Because if you have to report to somebody, you are more important than them in that line. But I'm not talking about necessarily import as being a great thing or not ever, but that was in her report, 6 slides in 2009, she said that. So if you look at what people are saying, it isn't people who are just having a gentle pop at things. In 2008, in a report, A Life Like No Other, the Joint Committee of Human Rights at the House of Lords and House of Commons effectively found this country guilty of violating human rights of people with a learning disability in terms of health service provision. In all but word, and I can see you're nodding because you know this very well, and I won't provide you with a quote, but when you get the slides, there is the quote for you. So we have that. What do we also have? We have from the now defunct Disability Rights Commission in 2006, again a body not known to prone to sort of ranting, that neglect, abuse, poor training and management of services are very poor for people with a learning disability. Complacency and lazy fatalism in their report, closing the gap about the equalities, health inequalities of people with a learning disability. This was a prevalent thing. Also, the attitude of people, well, they just do die younger, that's just the way it is. And people with learning disabilities just won't look after themselves. These were the findings that the Disability Rights Commission found in 2006. People won't turn up for their appointments, they're just not interested. And they also found that there's a significant lack of people with learning disabilities getting the same evidence-based healthcare treatment as other people. So that was in 2006. Before that, we had the Cornwall inquiries and we had everything else. And today we've had recently, the last few months, the Winterbourne View and the Care Quality Commission coming out and actually going to investigate those locked hospital environments and other such things. But what has changed the landscape beyond any view that it ever had before? Death by indifference. Death by indifference radically shattered the world of learning disabilities, and the world around it had to pick up and listen, had to take notice and do something about it. It's a horrific title, Death by Indifference, and to think that that was given to the report by a parent is even more horrific. That you actually thought your child died by the indifference of people who are supposed to look after your child. It's a very powerful title, a very powerful report. Not all of the allegations laid by MENCAP at the door of the NHS were substantiated once investigated by the Ombudsman. But Martin Ryan at Kingston Hospital did not need to die after 26 days of no food and nutrition. That's a fact, not a fiction. And one of the things that I've put in place, hopefully, in St George's will help that. We'll talk about that in a minute. Has anybody got any questions about that so far, about what's actually the changing face and where people think we're at? Is that kind of the picture that you feel you see around you? And you can also see that obviously the General Medical Council and others are taking more note, and I'm not suggesting for a minute the GMC didn't take note before, but they're able to use more of the evidence as well, just as I've been able to use the evidence. So, my talk is going to focus really on improving dignity, care and experiences and outcomes of people with a learning disability, but I'm going to talk about my role to begin with and how it was set up. In June 2008, I first of all went to see the Dean of the Faculty of Health and Social Care Sciences at St George's and Kingston University, where I worked as a senior lecturer, as also I was in clinical work as well at the time. And I said, you know, what I would like to see is a consultant nurse for people with a learning disability, because that's what's required in acute care because of all the reports and all the failings. And distinctly, the thematic evidence was that there's three key failings in hospitals at the time. That was leadership, accountability and responsibility. My role focuses on those three elements, as well as the other elements that a consultant picks up on. So she said, great, that's a good idea, let's go for it. I said, that's good, because I'm just about to go downstairs and meet the directors of the trust to have a word with them, and I'm pleased. Can I say that you were in agreement already? And she said, yes, that's fine. She wasn't surprised, having known me for a number of years, that was my approach. And I went and spent 20 minutes with the directors of the trust, and it was extremely easy to persuade. Why? Because the data's there, the research was there, the evidence was there. That's why evidence is so important to inform and shape how you use your practice, and how you also use the evidence to enable innovation to take place, even in these financially difficult times. So from that, obviously the directors agreed. We got 6 month interim funding from the NHS Bearing in mind St George's didn't have a death by indifference, and although we have 1,100 beds, over 7,500 staff, we're a large teaching hospital, and we, like other hospitals, don't get it right all of the time for people with a learning disability, we were not indicted by death by indifference. So I think it's to the credit of both the universities, Kingston, St George's, and the hospital, St George's, that they took on this kind of role and understood what it's about. I work 60% of the time as a consultant nurse, and that is 3 days a week. And 2 days a week I'm an educator and do research and lead and shape curricula and have other clinicians shadow me from all persuasions, so all disciplines, come spend time with me as well. So in brief, my role is to provide leadership, accountability and responsibility across every part of the hospital, to embed systematic change, for example, the reasonable adjustments, and we're going to talk about reasonable adjustments. People often use them and bandy words around, but actually don't really know what they mean. I'm going to explain to you how you can make them work, how they benefit patients in practice, and how they enhance the care of clinicians as well. Admission and discharge, I'm involved right from the very start, and prior to somebody coming into hospital. An example of that would be I often get calls right before someone's even in the ambulance to say they're coming to George's. I go downstairs, I meet with the medical consultant and the nurse in charge and say, you've got this person coming in, these are the issues that they need. They lack capacity, so you might want to consider some oral sedation. I'll come and assess when they come in, and we'll work very much together. In fact, I will plan the care with them of how this patient's journey will then go through the hospital. So we do it together. And I'm going to give you a brief example now of when I actually take the lead. I take over from consultants. There was a lady who came in. She had an internal bleed, and she was somebody who was being seen by 2 consultants in consultation, one of them being a surgeon, the other a non-surgeon but a consultant. And they called me in. And for those of you who aren't familiar, when a consultant calls in another consultant, what happens is they expect that consultant they're called in to take the lead role. That's the role. That's what they're expecting you to do. They're not coming in just for you to have a chat. They're actually expecting you to deliver something and to add a solution to the problem that they've now come to. So they were able to do all the clinical stuff that they had assessed the patient. They'd got that far. The struggle that they had come across was actually they weren't sure about her capacity. They weren't sure about really her history. They knew I'd seen her on previous admissions, so they called me in. So just so that you're aware of what happens, I met them in the room side to the clinic. We talked about what I was going to do. I was going to say, I'm going to do this, this is how I'm going to do it. That's fine. So what happened then, I then take over the consultation, and they sit back a little bit, so I'm closer to the patient, and it's me leading. To cut a long story short, what happened was I did the assessment of the person's capacity, asked her why she was here, what she understood about being here. She really had no idea. All she was talking about was bingo. And even when I said to her, you know, if you don't have this operation, you will die. So it's really the reality of the words are coming there. And she didn't register. She just asked if she'd be able to play bingo. So it was quite clear that she lacked capacity.
Did she come accompanied by somebody?
She did. She came accompanied by somebody. And unfortunately, and no criticism of this carer, what appeared to happen is that this gentleman had rocked up on shift, didn't know the person, and had done what was required of him. He'd been asked, go and take, for the sake of names, take Tracy to the hospital. So he'd done that. He'd brought her, but he knew very little. So we were in a difficult situation because he didn't know very much. She didn't have capacity. So when she went to the toilet, I said to the consultants, and those of you who don't know, when there's a consultation taking place in the hospital, in the clinic, there are beds attached to them as well. And so I said, you know, I wanted to be admitted, and could you admit her now? Because if she goes home, is she going to come back? I'm not sure. To cut a long story short, if you think about this, this is somebody who doesn't have capacity. A few days later, when I saw her on the ward, she said, "You're the guy who said I would die." So she had taken that in, but when I saw her, there was no indication that she'd taken it in. Absolutely none whatsoever, but she'd taken it in. Why does this demonstrate the significance of my role? Well, it demonstrates it like this, because the consultant surgeon who operated on her, about a week later, came up to me and he said, you know what, Jim, we thought you were being a bit pushy, but we went with you because we had a problem. We knew you'd be able to sort it out. But when I opened her up, she was a lot worse than we thought. And if you hadn't been there, in all honesty, we'd have probably let her go back home. What would have happened? We don't know. But it's because you were there that we did that. Yeah.
Do disabilities tend to affect people's clinical, their ability to tell how much pain or difficulty they're in, to give their history?
Yes, it does tend to happen. Good question. I mean, what can often happen is people's anxiety of being in, for example, we had a lady in A&E yesterday. She actually has osteoporosis of lumbar and spine, which was diagnosed yesterday, actually. But she, if you saw her, because her fear of being in hospital is so great, she was getting up out of the wheelchair and trying to walk away and everything. But you would see her and you think, oh, well, it walks relatively okay. But actually it's not. It's because she's overriding the pain because she just wants to get out. So people often sort of think that people with learning disability have a lower threshold of pain. That's often not the truth. The issue is that they experience and express pain differently. When they're experiencing pain differently, I mean, it comes out differently in how they may verbalise or non-verbalise. I've known patients that will sit down, and when they're sitting down, they'll do nothing, and that means, that actually they're in pain, but you don't know that because they're quite calm and quite relaxed, but they're just shutting off, if you like. So the threshold of pain, who can tell? I mean, that's a very arbitrary one. But one of the rules of thumbs that I look at is when I see a drug chart, I'll look at, is this a normal level of analgesics that you would give to anybody who's had whatever procedure or whatever they've got wrong with them. If it's not, why not? Oh, well, they're not expressing pain. I said, well, so they may not be expressing pain because they might be frightened to do so. They're scared in this environment anyway. Perhaps we should look at increasing it. And it's also about how you phrase it with colleagues. Then they'll turn around and say, well, what do you think we should do? And then you can offer solutions. So it's that. But in essence, it's about using the experts that are people themselves and their carers and relatives to be the guides about the pain, because people can have very subtle changes and you can miss them very easily. I'll give you an example of when we had a case, and it was in intensive care, and one of our nurses thought this person's guttural sound was them being in pain, and he gave analgesics for the person. And the sister then came, the biological sister, the person's biological sister came, and he had expressed this, and actually she said, no, that's not him in pain. It's normal. But she wasn't there at the time. Did he do the right thing? Absolutely. Because clinically, the person had had an operation, he had had an operation, she as a nurse didn't know, but it was to be expected this person might be in pain. The sound they made sounded like they were in pain. There's nobody else to tell them that this is a normal sound for this person to make. Therefore, they gave the right thing. But it meant that the nurse actually had quite a lot of discomfort because they actually thought that, and I said, no, you haven't. Anybody would have done what you've done because it's actually, you followed the right way. In fact, you did really, really well. And the biological sister actually thanked the nurse as well to say, that was the right thing to do because you came to the right conclusion and it could have been they were in pain. And I wasn't here to tell you. So we got from that a very detailed account from the sister exactly what sort of sounds are we talking about, how long is it in duration, so we don't keep giving somebody a drug they don't actually require, if you see what I mean. So that's that one. So that gives you that example. Also to provide safe, lawful practice. Unfortunately, the vast majority of clinicians in this country have no training whatsoever. Legal qualification. They maybe have training, but they don't have a qualification under the Mental Capacity Act. That's something I think should change massively. I'm a best interest assessor under the Mental Capacity Act, and it is a specific role that looks at deprivation of liberties and assessing whether someone A, lacks capacity, and B, is what's happening to them deprivation of liberty, and is it lawful then to detain them with the conditions and requirements attached, and what duration of time can that be done. My concern that there aren't many is because I think it raises a number of questions of how people reach assessments of capacity. For example, somebody saying they want to get better and they can tell you part of what their treatment plan is, doesn't mean they have capacity. If they don't have all 4 elements of the assessment criteria, then they actually don't have capacity. It's a complete lack of capacity, and it's quite easy to assess that. And I'm going to give you examples later on. I won't give you... actually, no, I'll give it to you now. This is how I do my capacity assessment every single time, without fail. And the reason that I know that I do it this way is because I always ask the same questions. It's good because it's a repetitive motion. It means I will always get it the same way. So I'm going to give you a real example that was on, and this is a plug for BBC Radio 4, Best Interest Play. It came out on July the 14th. It's got some of the cases in there that I gave them. I was the clinical advisor for the play. But it was an exceptionally well-written piece. I didn't write it.
So can you repeat what it was?
Yeah, it's called Best Interest at BBC Radio 4, and it came out on the 14th of July. We'll call this guy Tony. It's not his real name. Tony was in one of our side rooms, wasn't very well, wasn't eating and drinking, and I said to Tony, I said, what's happened to you? And he said, I'm not eating and drinking. And I said, okay. And note very clearly the phrases I use, these are almost exactly the words I used to Tony. Okay, Tony, so you're not eating and drinking. Has anybody said anything to you about what we can do to help with your not eating and drinking? And he said, yes. I said, what have they said? They talked about a tube. I said, okay, so this tube, what's it for? It's for eating and drinking. I said, okay, so this tube for eating and drinking, where does it go? Into my tummy. I said, okay, so this tube that's for eating and drinking goes into your tummy. Now, I don't care if he thinks he's going to get burgers and Coke stuffed up the tube. It's totally irrelevant. Nor am I bothered about where in the belly he thinks it's going to go. I then said to him, so what happens if you don't have this tube for eating and drinking going into your tummy? And he said, I'll fade away. I said, no, you will die. And he burst into tears. Now, why did I say, no, you will die? Because fade away is abstract. What does he mean by that? The reality is, we're life and death here. There's no ifs and buts and maybes. You don't have it, you're dead. You do have it, you might survive. But it's still an issue. So, through his veil of tears, he said, I said to him, so what we can do? And he said, I'll give it a go. So there you've got complete capacity. He understands, he can recall the information, because I never gave him any of the information. Remember the words I used. I never gave him any of the information. I used the words back to him, but I never gave him the words. So I just said, so the tube for eating and drinking, where's it going to go in the tummy? So what happens if you don't have the tube for eating and drinking that goes into your tummy? Notice the way I just used the words back, but there was always something new, and I always used what he did. So I was checking his understanding the whole time. Now, he had capacity. He wanted to give it a go. Unfortunately, he was too sick. He got an infection, it didn't actually happen, and he died. But that's a very good example for the fact that it's very simple. So it's very easy. So my tip on capacity assessment is very easy. We had a young lady, a 17-year-old woman, who was in with us today, this morning, and I saw her, and the first things I always said to her is, do you know where you are? Do you know why you're here? Okay. And what are we doing for you? So she started off by saying, they've taken blood. I said, what's the blood for? She says, for my leg. I said, okay, so the blood from your arm is for your leg. She said, no, it's to check my leg. I said, okay, so the blood from your arm is to check your leg. How do we do that? It's because we'll see if it's wrong. What's wrong? My blood. So that's the way that she's got it. So if you're doing it that way, again, she understood what was happening. Now, did she understand all of the bits? No. But did she understand enough of it? Yes. Yeah.
2 points. First to go back to the first case, it's a very sort of bold statement. I'm not sure when I say that to patients who have capacity, what happens if you don't do why you'll die. It's very, I'm interested in the kind of subtleties of how we actually communicate with people in general and how that has to be modified for people with learning disabilities. And secondly, again, this issue about the blood and the leg, again, lots of patients with competence have a great, they're not going to say to me, well, it's an inflammatory marker.
No, exactly. And that's why you don't need that. But you see, she knew what she's got wrong with the leg. She actually got swelling in the leg. She had an insect bite and it's flared up. So she knew that was. So that's the connection. I just truncated it very briefly, but it was a bit longer than just a 2-seconder. But in terms of the bit about the dead, about saying that you're going to die. It's got really, as you know, because the bit about the Mental Capacity Act also is about they're able to weigh up the pros and cons, benefits and risks. Now, fade away is an abstract stuff. Now, does he know what does he mean by fade away? Does he really realise that we're actually at death's door here for him? And does he know this is actually last chance saloon? Or does he think it's something else? I need to be sure. Now, the reason for doing that is because a lot of people with a learning disability, by the nature of having a learning disability, are not able to consequentially look at the future and the time lag that happens. So projecting into the future, if I do this, this will happen. Consequential understanding is often not there. And certainly when people are compromised with ill health, then their cognition, as you know, is diminished as well. So that's my thinking behind that. I need to know that he really understands. Because I document in his notes, and if we had a copy of them, you'd see my whole transcript of our conversation in there. So I then can put at the bottom, so no other clinician can dispute this, that conclusively he has capacity. And even people still questioned after that. Would people have questioned his capacity even more if he had said, I know that tube, I don't want it? So there would have been a capacitated decision. Might be unwise, but he had capacity. So that's another thing that didn't happen in this case. But if it had, how would that have been? So I think there's a whole range of things. I look at improving the health outcomes. That's a bit about the law. I look at improving the health outcomes of patients, and I'm going to give you some examples of that as well. How are we doing for time? Fine. Leading research and guidance development, educating and supporting professionals, as you might expect. And I work together very closely with people with learning disabilities, family carers, community staff, as well as other hospital-based staff. So, in essence, what my role really involves, as you've just heard, is leading, guiding, shaping, and providing expert advice to people. I will be called in, just as any other consultant in the hospital, to make decisions very, very quickly with limited information, and I'll be expected to guide the trajectory, the pathway of that person from then on in. I'll give you an example. One of the medical consultants in A&E bleeped me because a very highly competent junior doctor was struggling with a patient who had had a shunt put in about a week and a half before. He was now complaining of right-sided jaw pain. This is a guy with a mild learning disability. And she was trying to get blood from him. And he was saying, yes, no, I want to get better. She did not understand that actually, by no fault of her own, she was actually precipitating his anxiety. She was making him more anxious. And we were in a situation where things could go wrong very quickly. I was called in, and it took me a short time to realise, very short time, to realise that actually this guy quite clearly lacked capacity. We needed to do something. So my role in there was to say, okay, he lacks capacity. This is why he lacks capacity. This is what I'm suggesting. Give him some oral analgesics. He's needle phobic as well. Give him oral analgesics. Not analgesics, sorry. Oral, you better change that on the tape. Oral diazepam or lorazepam, just to sort of calm him down a bit. And then, if we needed to titrate up to full sedation. Now, you might think that's a bit excessive to take blood. Well, what else are we going to do? The guy is clearly stressed. There's something going on. We've got to find out what the cause and what's progressing forward from him. But obviously, each time you increase the trouble, you need to be careful as to why you're doing it. You need to assess why you're doing it and what the purpose of it is for. This person, we didn't need to go any higher than the normal sort of small dose. I think it was about 4 milligrams, if I remember rightly, something very small dose. But it just took the edge off for him. We were then able to treat him and get to the bottom of his problems.
Is that because once you've given him the anxiolytic, he's then able to give you, it was then informed consent, informed consent in capacity? Are you saying that because he was so anxious, that was the thing that was limiting his ability to give him consent?
No. His limiting, his lack of capacity was understanding that we needed to take the blood, because without taking the blood we can't analyse what's actually wrong from, therefore to develop the treatment plan for him. He didn't have the understanding. He wanted to get better, but he had no concept of how he was going to get better. He just knew he was in a hospital and he wanted to get better. And he was getting more and more stressed. It was in the clinical best interest, and he became very sleepy and very drowsy. His mother was there around the time as well, and we spoke to her. She was happy for it, obviously, as well. And it was a very clear decision to do that, because otherwise we wouldn't have got anywhere for him. And it was the only way to treat him.
And assault is if you do something to somebody who has capacity,
yes,
and then say,
yes,
I'm not doing that.
Yes.
So
this was not assault because he lacked capacity. And because he lacked capacity, we were free under the Act to act in his clinical best interest, which we detailed very, very clearly. And also, as you know, that at times under the Act you can also conceal medicines if it's in the person's clinical best interests. If you can demonstrate that the person is at significant risk to themselves and to others, and giving them, saying to them you're going to give them this medicine, they won't actually take it, and there's such a risk. We've done that once since I've been in post. Yeah, we mixed it with something, and myself and a medical consultant agreed that we would conceal it. I would give it, and I would not tell the patient I was giving it, because she had actually we just had to push her out of the way of running into an ambulance, in the path of an ambulance turning into A&E. So this was a woman that was at significant risk to herself and to others, and was getting higher and higher in terms of her anxiety, and the risk was getting greater and greater. So we had to assess what the safety for everybody, but the safety for her as well. It was the only way we could do that was to give her, and it actually worked, a small dose, and it worked, a small amount of oral lorazepam.
And clearly you're brought in because the clinicians lack confidence in doing this, but to making the best decision. But any clinician who is demonstrably competent in making that kind of best interest decision is able to do so.
Absolutely. But I think the thing is also, it's because it's more about the fact that I probably know the patient before, I've worked with them before, but also I've spent over 20 years of my life just working with people with learning disabilities. So it's the added things as well that comes in, and also it's what would take them quite a long period of time for discharge planning, for example, would take me a lot less time, because I can get stuff that I want quicker and I know the system. So moving on from that, I can protect beds in advance of admission. So for example, Jim Blair's coming for an operation, that's a protected bed, it's only for Jim at that time, and that's fixed. That person will do that. We've done that for people coming in from Ireland. We've had patients coming from all over the place as well as locally. And this enables a lot of improvements to be made, because I can forewarn all the clinicians involved in that person's care about vital information about how they communicate, what their health needs are, and ongoing issues that they may need to face. And this reduces the stress for the patient and for the family. So it's a really powerful use of time to have. I can also block discharges if I deem them to be unsafe. My decision is final in terms of somebody with a learning disability in the hospital if I feel the discharge is unsafe, because somebody might very well be medically fit for discharge. That doesn't mean they're safe for discharge. They're two separate things. And you might think, well, do my consultant colleagues have a problem with that? They don't. They completely get the picture. How that works in practice is, for example, if someone says that Trevor's medically fit for discharge, consultant X says that to me, and I say, well, actually, I don't think Trevor's actually safe for discharge, so he's staying in. We'll have a discussion about it, but what will happen is that consultant will no longer have that person on their rounds, as it were, in the bed. The person will stay in the bed, will have nurses doing observations for the person, and will be virtually their consultant, but actually will not see them on the ward round, okay? Because they're in, because there's another issue, normally social, or it might be a mobility issue, that they're actually unsafe and we need to get a package of support in, or the physio is not happy about something, or a speech and language therapist isn't happy about something, and we need to do just further investigations, but they do not require a medical consultant to be involved in their care, okay? So then they'll be discharged from that into my care, if you like. In order to stay within the law, and I can see you smiling, that's where the virtual fact that they still remain their consultant, because everybody has to be under consultant in a hospital. So that consultant will know they're still in hospital, but will not see them on the ward round. So if they're in a bay of 4 people, they'll see the other 3 patients and not that patient. But if the nurses have any concerns, they'll do the obs. If there's any concern, that automatically comes fast-tracked back to that same consultant, and they will take over the care again. Okay, so it's not that people don't have blood pressure, pulse, and all the rest of it done for them. Okay, I mentioned a speech and language therapist, and I'll talk about an unsafe discharge. There was a chap who came in on bedside assessment for dysphagia, a major problem for people with a learning disability. She assessed that there were significant swallowing problems, and her conclusion was it was more than likely that it was esophageal damage, but only a video fluoroscopy would see that. And that was on a Tuesday. Day of the week is important because only on a Thursday do we at St George's have a video fluoroscopy clinic? Because you don't need to have them every day of the week. And the reason for blocking the discharge was that if the patient had gone home, would they have come back for Thursday? Would they have got on the list for Thursday? Probably not. So I blocked the discharge. Thursday came. He was assessed. Sadly for him, it was found that he was aspirating on everything and he would need a peg. So what actually had happened was that the assessment from the speech and language therapist was correct. Could that person have gone home and choked in the intervening days? Of course it could. Could they have died? Yes, of course it could. So it's also that. It's about having that in place where you have a senior clinician that just says, that's it, this is the decision. Now, obviously, if people would choose to override it, that's up to them, but actually it'll be their responsibility and not mine. I've made the decision. Thankfully, that doesn't happen. I enable community clinicians to come in and assess patients whilst they're in hospital. For example, we had a chap who was behaving strangely in a medical way. Myself and the medical consultant were just sort of scratching our heads trying to work out what was wrong for this guy. But actually, he had just been put on phenytoin, which is an anticonvulsant, and I said, well, I know the consultant psychiatrist is an epileptologist in the community who looks after this chap. And so I gave him a call on his mobile and I said, William, could you come in and assess this guy, please, because we think it's this. And he said, yes, it might very well be, given what you just said. He came in, assessed him, said, yes, it is this. Take him off this, put him on this drug. Now, obviously, he's a community practitioner. He can't prescribe in the hospital. But what the next entry was the consultant in the hospital saying, follow what William's saying to the letter, and this is what I'm now going to write up. Now, we got that guy out probably 2 or 3 days before we would have done otherwise. We also saved him an awful lot of tests that we would have run because we had no idea actually what was going on for this person, and that rightly we would have done a whole load of tests, but we would have taken a long time coming to the conclusion that was much quicker by getting a clinician in from the external. I act as a second opinion. Consultants from other hospitals ring me up or email me for second opinion or advice, and I'm happy to do that and document that appropriately. Reasonable adjustments that we set up, you've got them before you. These are the core reasonable adjustments that we have in the hospital, and these are our commitments to the Disability Discrimination Act and the Quality Act, sorry. And these are the things that we do, and some of the things, if we don't do them, I want to see the complaints flowing in, because actually, if we don't do them, we're then actually in breach of what we're saying we're doing to comply with the law. Yeah, you can have that one. And these are housed on the Trust intranet page, yeah.
And how accessible are your complaints section?
Okay, good question. There are not many hospitals in the UK that have people with learning disabilities complaining. It was one of the big problems of the Ombudsman and others. We have had 2 people with a learning disability going through the full complaints process since I've been there, and I'm extremely pleased with that. Both complaints were made directly to me. They requested that I came to see them. Obviously, guys with a mild learning disability. One was around issues around security and how someone had treated them. The other one was around issues around transport. And that went through. Accessible format, yes, they are much more accessible than they were previously. A letter came to me for them, for me to look at before it got sent out, and I said, look, this is what we need to write. It was about 6 sentences, and it was about, because I know the guy can't see very well, he holds the paper right up to his eye, and it was in about point 16. But he didn't like pictures, he would have wanted words. So it was how he wanted it, so it was tailored to him, and he was really pleased with the outcome. He met with the staff, talked to them about what he thought had happened, and they talked about what they thought had happened, and he was happy with that. Reasonable adjustments, well, you got them before you, things like first and last appointments. Yes?
Sorry, can I
yeah.
I'm interested by the hospital's approach to, you say you have a list of reasonable adjustments.
Yeah.
I mean, the law doesn't say that you have to have a list of reasonable.
No, it doesn't.
In fact, every case should be judged.
Absolutely.
It's an anticipatory, ongoing
yes.
duty. It is the Equality Act now.
Yes.
Not the DBA.
Yeah.
But presumably, if you had someone come in who required another type of reasonable adjustment,
yeah.
you're looking not only at
yeah.
also age, looking at policy, practice, procedures, or physical adjustments, this is not a sort of inflexible.
No, this is the core. This is the core commitment. You're right about the list. No, it's not an exhaustive list. These are the core. These are the ones that you will get. There's others bespoke, which is what you're referring to, and I'm going to give you some examples of that. Things like no fixed visiting times. People can come whenever they like, stay as long as they like. They should be offered a bed or a chair to stay with them. They should be offered food and drink. Because the experts, as I said at the beginning, it's the arrogance of health professionals that have led to the deaths of people with learning disabilities up and down the country and throughout the world, and the inequalities that exist. The experts are people with learning disabilities and their parents themselves. We work alongside them. Actually, we get it right an awful lot more of the time. And just to give you an example of the issue that you raised, we had a gentleman who is on dialysis. Obviously, he's got problems with his kidney, pretty significant. And during his dialysis, which lasts for 4 hours in duration, he pulled them out, all the tubes out, within half an hour. Blood went absolutely everywhere. He had it. In his idea, he had dialysis. People said, oh, he lacks capacity, Jim. You said he had capacity. I said, yeah, he does. He does have capacity. No, he doesn't. And it became a bit like a pantomime. I said, look, okay, this isn't a charade. The reality is, he does have capacity. I've talked to him about this. He knows if he doesn't have it, he will die. And he will tell you that. He's very clear. He's very limited in terms of his expansion on anything. It's like, this is what happens. He's very concrete. So he would tell you exactly what he understands by that. The reasonable adjustment was that he has a healthcare assistant with him for the 4-hour duration. They dissuaded him, they encouraged him, they watched TV, listened to music with him, and then that 4 hours faded down to 0. He now has it totally by himself, and he was one of the complainants about one of the people that he'd got, about the security stuff, that he was actually transport one, sorry. So if you look at that, what area did people think that he lacked understanding on? Now, if you think about where did my colleagues come from with that? Well, they thought he lacked capacity because he lacked a concept of time. Wrong. Lacking a concept of time does not mean you lack capacity under the Mental Capacity Act. He would never have a concept of time. You could tell him it's midnight, well, he'll tell you it's not dark. He could probably work that out. But telling him something's half an hour, 4 hours, 5 hours, he's got no concept of that. But he has got the concept of what's happening, what's the treatment plan, where he's going and all of that. It's just that he doesn't have an understanding of time. That's actually a side issue. It's not the core issue. So that was one there. Altering the environment. We had a lady came in with tuberous sclerosis, severe learning disability and severe physical disabilities. Myself and the pre-op lead nurse went into the side room after she had arrived. She came in from Dorset with her family, obviously pre-planned, obviously protected bed, all the rest of it. And it was a fantastic shock of pink. We opened the side room door and it was brilliant. It was like going into a teenage girl's bedroom. Well, she's a teenage girl, what's the difference? Because I said to her mum, said, oh, can I bring things? Yeah, bring what you like. She's got music booming out, some pink stereo, everything. It was just like wall-to-wall pink, except she hadn't painted the walls. Pink duvet, pink cushions, her wheelchair was pinked up. I mean, it was just absolutely brilliant. And I've got the photos, which I do use in talks, examples of that. It's really quite an amazing experience. That changes quite a lot of people's perceptions of the person's quality of life and their experience of life. And it's a very good thing to do for people. We use signs, symbols, photos, words for people. A variety of equipment adaptations. I've said about protecting beds in advance of admission, educating staff, the hospital passport. The hospital passport was built from one that was developed in 2005 or 6 in Gloucester, and it was developed in partnership with people with learning disabilities, family carers and clinicians, both hospital-based and community-based. John O'Neill, who his name's mentioned, I've written about this, and he's been pictured with me in the Nursing Times, and he's more than happy for his name to be mentioned, said this about the hospital passport. Nurses and doctors know how to help me because of the passport. The hospital passport, if you haven't seen them, they're over there, but it's this thing. You've got it so that the red, things we must know about you, yellow, important, and green, likes and dislikes. The hospital passport, quite simply, saves lives. I'm going to give you 2 examples of how, without a doubt, the hospital passport has saved people's lives. So there's no dressing it up any other way you want to look at it. A man with Down syndrome, not too dissimilar in age to Martin Ryan, the guy I told you who died at Kingston Hospital. By the way, Kingston came out of death by indifference, I think, extremely well by owning up straight away that it was appalling what happened. And they've done massive changes to make things better there as well. And this chap with Down syndrome came in, he was in a medical assessment unit, and he and the carer didn't know why he was put nil by mouth. And neither did I at the time. So I went over and I saw the medical consultant. She was actually on the phone at the time. And when she came off the phone, I said, why did you put the guy nil by mouth? And she said, well, because I read, operative word, read, that in the passport he regurgitates food and bubbles up liquid. I did what? Emergency dysphagia assessment. I could have hugged her. Brilliant. Brilliant. She's A, read the hospital passport, B, she's acted upon it. Which isn't actually something we would necessarily have picked up from the person that. So when I went back to the carer and to the person themselves, and I said to them, because of what you've written, this is why. And they felt really good that they were genuinely involved in their care and treatment, and the whole pathway of that person's journey changed because of what was written in the passport. Another one, a lady with severe learning disabilities and chronic respiratory problems, was on one of our wards, and the sister, the nursing sister, read in the passport, read again, that she's allergic to eggs. Well, it could be an anaphylaxis reaction, or it could just be rash. Former life-threatening, latter uncomfortable, not to diminish it, but it's uncomfortable, easy to treat. Carer wasn't there at the time, so what does this nurse do with this information? Well, the sister actually rang the home to find out if it was the former or the latter. Thankfully it was the latter, but even if it had been the former, what could we have done? We could have made sure that the trace elements of egg were not in the foods and drugs, but even if they were, because that was the only drugs type we could give, we would be able to have a nurse with them all the time, or a healthcare assistant attached to a nurse that would be able to then pick up any problems. So those are two very key things that could have saved those people's lives if the passport hadn't been in there. It also provides people with dignity in personalising their care. For example, we had one lady who has a particular like for Elvis, and also is frightened of the dark. Well, the two don't normally go hand in hand. But if you're frightened of the dark in an acute hospital, it's not very clever at night time because the lights go down, you scream, get freaked out. Things can go very wrong pretty quickly for you. People could think you've got psychiatric problems, or a whole host of different things could happen. So what we did with the nighttime issue was close her curtains and put a light on. So she was always in the light. So the lights would go out at night, but she was staying in the dark. With Elvis, people would talk to her about Elvis before they did blood pressures or any intervention, which meant that A, she was relaxed, and B, they actually could get to do the things that they needed to do for her. So improves patient safety. I've given you the examples there. It helps with clearer discharges because we understand the person. It stops people asking the same inane questions again and again upon each admission. And basically, the hospital passport, I think, should be used everywhere. It's used widely, but we really should just have one hospital passport, whatever passport it looks like. But it should be used, in my view, for any patient up and down the country. We should all have one, a bit like the child health record that's around for children. And we just add and take out pages that aren't relevant to us or become relevant as we move on in our journey in life.
Can I just say,
yeah.
We have something very similar in Hackney that the Homerton's been using, the Purple Book.
Yeah.
And when you've heard of that, it's very similar.
Yeah.
But I think one of the issues that we've had there is that it is actually getting people with learning disabilities to get it out there to everybody. We reckon in Hackney there's something like 650 people with learning disabilities, and a small proportion of those people have actually had access and had support to actually fill out the Purple Book. So it seems like once they're in the hospital, then there's an opportunity to get it done, but it's actually getting it done before that happens.
Yeah.
And also, if it's coming out in different fashions, organisations like Makeup or whoever wants to kind of campaign for this to happen will find it a little bit difficult if it's not consistent.
I totally agree. I totally agree. And I think the thing is how you get saturation, if you like, is to link up with our GP colleagues who, contrary to a lot of people's opinions, are actually very, very good and very helpful, the vast majority of them. And they will use them. If you have it online, we have it on the Trust Intranet. I'll send people them electronically, but community teams have paper-based copies, GPs have paper-based copies, residential homes have paper-based copies, so they give them out. And also, we have over 50% of people who come in with a learning disability who come in with a passport of sorts. Because if somebody's got your purple book, let's say you've been at a hospital, I'm not going to give them this. There's no point giving them another book. Great, it's the purple book. As soon as I get that, I'll write that in the medical notes. Don't bother about giving them a passport, just look at the purple book. It's the same sort of thing, because people have, this is my health, or whatever. Fine, whatever you've got, great. Don't repeat things all the time, because there's no real benefit in that. So I think that a lot of it is just common sense, but the passport is used widely throughout this country, and this particular version is used now in many European countries, and in Australia, Canada, America, and going to be Norway next week. The saturation level from that comes, and I make no bones about it, it comes from my work with Special Olympics Great Britain, because I'm the clinical director for health promotion, the vice chairman of Special Olympics. So I go to the game, when I go to the games, and I do the screening of athletes, I make sure that other consultants from all over the world that are there and other clinicians get them, do it. And there's no copyright, so anybody can have it. Dementia Passport was built from it. That's used at St George's and elsewhere. So there's lots of different things that we can move forward on that. But I think one of the most exciting things that's happened in terms of the passport is we had two medical students who, for part of a research project they were doing, wanted to look at the impact of what doctors and nurses thought of the hospital passport and how it changed the care pathway, because it's very easy for me to sit here and say how wonderful it is. But actually, what do people themselves think and what do the clinicians think? That study's been concluded, it just hasn't been reported yet. And I've also done a study on what people think of the impact of my role in 2010 and 11. We're doing the analysis now. So there's going to be quite a lot more coming out as we speak. But one of the best things that's ever happened, and I feel sad that, to my knowledge, I'm the only consultant of any persuasion that's actually held to account directly by those they serve in this manner that I'm going to tell you about. LD Our Health, Our Hospital, I set up in March 2010. It's made up of people with learning disabilities, relatives, and people from other charities, chief executives of other charities and other leading people in charities. Locally, the chair is a joint chair. Two people with learning disabilities are there. And then the vice chair is the chief exec of MenCap locally, and the other vice chair is a parent. And they hold me to account, which is absolutely wonderful. They, obviously I'm held to account by the Trust Board, and that's important as well. But this, for me, is personally much more rewarding, because they say what they want to develop in the hospital. They're very engaged in it, and I'll give you examples. They were on Access Committee. I don't know if you know about changing places, toilets. Well, we're going to have one. Thank you, you're very welcome. If you want to email me, you can get my details. You've got them there, so do, yeah. And they act as a real local people with local decisions about what they want. They say how they want the hospital to run in terms of people with learning disabilities. They give me feedback, but good and bad, from what they've heard. They hear about referral rates. I average between 34 and 36 referrals a month to me. So where to now? Well, there's a lot of exciting things happening. We have just started a 22-month research project looking at patient safety in acute hospitals, and this is being led by Baroness Professor Sheila Hollins and Dr. Rainey Tuffy in the medical school, and I'm the clinical lead for it. And this is with ourselves, Kingston Hospital, Croydon University Hospital, Basildon, East Berkshire and the Great Western Hospital. So that will be a very interesting development and where we go from there. So what do professionals really need to get? Well, I think what really needs to happen is that people in the learning disability field have to stop bashing. By that I mean, I have not found evidence of people deliberately wanting to be nasty to people with learning disability. And sometimes that's the impression that people in the learning disability field have, or think they have, or inadvertently actually give off. I don't find that. I really don't find that. I find actually far the reverse. That I said at the beginning that people sometimes are frightened, fretful of doing the wrong thing. So it's rather that they are maybe slower to act on things because they're not actually sure what to do. They're not confident. There's not been the training in their professional career pathway to guide them, to shape them, to understand what's happening. So sometimes it is a matter of being frightened. But also what we've got to remember is if you're in a busy A&E and you're a nurse triaging a patient, you might have 5 or 6 people in your head at a time that you've got to think, oh, I've got this person to do, I've got this person to do. Now I've got somebody who learned this, oh wow, you know, I've got all this and they've got really complex issues. Then I've got somebody with a mental health problem over here. Then I've got somebody who's misusing alcohol and drugs over here. And I've got all these people that each are very, very complex. And you can see how things can change for people in the pattern. I think people need to experience the reality before they critique things. I think MENCAP and the General Medical Council, and I'm not just saying this because you're here, have done a wonderful thing in moving things forward with the play and the podcasts that are coming online for GMC and the work that MENCAP's doing and their approach to getting it right is very much the one I've just said. It's about supporting people. It's about highlighting good practice. When poor practice and when terrible things happen, it's not about hiding them. It's about alerting those as well. But it's about supporting people because if you look at the root cause analysis, when things go wrong, very often it's because people will have diagnostically overshadowed something because their inexperience of working with people with a learning disability means that they'll put it down to the learning disability. But it's people who know people with a learning disability who then say, actually, this is a change in behaviour. Why we need to look at a biological reason for behaviour change rather than just go down the route of challenging behaviour this, changing behaviour that. I'm not quite sure what it is. But we need to look at what are the biological reasons for that. So I'm going to give you one last example for the law point of view, and also of behaviour change. You may have read in the papers a horrific case last year of a gentleman who snapped his neck in the sides of a bed in a hospital. You could say, well, that's never going to happen in the hospital in which you work. Wrong. You can never say never. I don't know that we're not going to have death by indifference. I can't guarantee that. What I can do is make sure that I reduce that likelihood as much as I can, but I can't guarantee it. We had a chap who came in, 22 years old, has severe learning disabilities, lives with mother who's about 5'4", he's about 6'2". The height difference, really important here. He started to get very distressed, smashed the car up, smashed the computer up, got very, very angry at home. Obviously mum at a risk here. Even if it turned out he had no history of being violent or aggressive to anybody in the past, but, you know, just pushing mum a little bit is going to mean that she flies across the room, and she's quite a small, frail person. He came in to us, and with colleagues, it was my decision that we have him fully sedated, because this guy wouldn't tolerate any treatment, and he was very unsafe. He has severe learning disabilities. We knew that what was going on, and we needed to find out what was wrong. Was there anything wrong biologically? So under the Mental Capacity Act, he lacked capacity. It was a clinical best interest to keep him sedated. We did that in ITU, in a side room. He was on the floor with a mattress with pillows all around, with the sister, a nursing sister, always in the room. Okay? And we went through every single test we could think of for him. We even have in our ITU a dentist who happens also to be a medical doctor as well. So he said, I'll check his teeth. Everybody checked everything. We checked him once, we checked him twice, because we couldn't believe we were finding nothing wrong with this man. And yet the behaviour was like this. So was it then a mental health problem? So now I've got the dilemma of, under the Act, Mental Capacity Act, he's staying sedated. We know there's nothing biologically wrong with him. Can we lawfully keep him sedated? No. We bring him out of sedation, what happens? He's getting very agitated, very aggressive, very difficult to support, and it's not an environment where we can safely support him. So then he had to be sectioned, so that's when the Mental Health Act came in from the Mental Capacity Act. Mum was content, not happy. She was tearful, as part of the group sectioning with the consultant psychiatrist, and I was present. And to cut a long story short, he was sectioned, went to a psychiatric unit, no behaviour problems, no psychiatric issues. Okay, this was strange. Went back home, behaviour increased again. Went to respite service, no behaviour problems. So what the conclusion was that actually he was a young man who wanted to actually be away from mum. And this was his only way of doing it. And you could say, well, that was a very long route of finding out. How else are we going to find out? This is a guy who's no verbal language. He has no capacity. We would be guessing at any interpretation. But I'll leave you with the point of that actually is very good practice. He was sedated and he was found. I'm going to give you one more example of very good use of the Mental Capacity Act and also the second opinion that I got. A consultant psychiatrist in a hospital in London, psychiatric hospital obviously, he rang me up and he said, I want to run this past you, I want your opinion. And this is the only bit of information, I don't know anything else about this patient, but this is what he's done. He said, I've just sedated this guy, and I said, okay, how much you sedate? I put him to sleep. I said, okay, why? And he said, because he's in renal failure. Bear in mind, this is a psychiatric unit. He cannot treat renal failure there at all. But he knows that he's got it. He doesn't know the severity of it. But this is a guy who will not tolerate any investigation. So I said, okay, I'm going to ask you the questions I'll ask anybody. So I said, right, you've done the capacity. He said, yes. You've got a mental health problem? Yes. Okay. You've done this because it's in his clinical best interest. How do you know he's got he's in renal failure? Well, he's told me. Fine. Okay. So you've been able to say there is a significant problem. You've got concerns. Right. What drug did you give? Okay. And have you called? You've told the ambulance and you've told the taking hospital. It wasn't George's, by the way. You told the taking hospital, and you've given all the details. Yes. And do you think he needs to remain sedated whilst they're doing the tests for him? He said, yes, without a doubt. And I said, have you also told them that? Yeah. I actually think that's a wonderful piece of clinical decision-making, and it quite clearly meant that this person could get the treatment that they required. Now, whether the clinicians in the taking hospital then feel that they can take him out of sedation at certain points, that's where they will discuss it together. But from my point of view, I said that's excellent practice. Just document our discussion in the medical notes, and I agree with you. That's good practice, and that's what I would have wanted should your patient have been coming to me at St George's. Okay. I can't think of anybody who would criticise that course of action. But if we didn't do it, would that person have got investigated? No. Would they have possibly smashed the place up? Yes. Would it then have caused more hospital-phobic behaviour for them? Undoubtedly. You'd have gone through a huge array of problems, but that was your solution. Okay, I'm going to leave it there because I think it's really open for you for questions.
Yeah, we've got about 5 minutes for questions, if anybody would like to ask any or make any points.
When you say that somebody does have the capacity to say to tell you that they've got renal failure, how do you know what information they can give you, and how do you know what they might be withholding or what they might not understand about their situation? I find that very difficult.
I think things like renal failure are difficult because it's more likely that can actually cause you to compromise your cognitive function anyway. And also, when you're in acute hospital, your cognitive functioning, any one of us, would be diminished. Why? Because you're sick or ill in some way. You're also anxious, frightened and scared. You're in an alien environment where people have perceived power over you and you don't know really what's wrong with you. So your cognitive functioning is going to be diminished. You add that to the fact that somebody's got a learning disability. Their functioning capacity is going to be even more diminished. So that's very important. You just have to go through, as I was saying, the step-by-step approach. What's somebody coming in for? Do they understand? Can they let you know what's going on? Do they understand what's happening? Do they understand the options? Can they weigh up the pros and cons, benefits and risks? And recall and relay that back to you in their own words, just like I gave you the example before. If they can do that, clearly they have capacity.
But do you not sometimes get the case where they can do that partially to a certain extent, and they can answer some questions but not
Doesn't
others?
matter. It's very black and white. The law is extremely black and white about that. It's you either have or you haven't capacity. You don't have 2 out of 4. You don't have 50% capacity. What you could say in there, and what I was documenting, for example, the guy with the shunt, was that he wants to get better. He does want to get better. He has no idea how he's going to get better, but he wants to get better. So that's his wish. But to get there, he can't make the understanding, you can't make the connection. But also it's about making sure that capacity is time, location, decision specific. We had a guy who came in, he had mitral valve prolapse, and he also needed dental treatment. So what we did is I separated out the two treatments. So let's do the dental one first. And that was the one that was going to be done first anyway. I asked him, can you tell me why you've come in? Yes. Dental extraction, big word. I wondered if you really understood what dental extraction means, as you can appreciate. So he's heard it, so is he just repeating it out? So I said to him, so, extraction, what does that mean? And he pulled down his gum and he pointed, and then he with his finger he pulled out. So he was showing me that it means it's going to, and then he actually said to take it out. I said, okay, so that's what extraction means, they take out. I said, okay, so they're taking out your teeth. Have you ever had it done before? Now I could see that he had, because he's got false teeth, and he said yes. And I said, so what happens when you have it done? And he went like that, and I said, what does that mean? No pain. So he knows he's not going to have pain. And then, how do you think you'll feel afterwards? Okay. So he's all right with that. Now, he understood that. What he didn't understand, when it came to do the heart, he had no concept of the pros and cons, couldn't weigh up the benefits and risks. But he wanted to have the treatment, but he lacked capacity for that. And that was some days after he had the dental treatment. He did not have capacity for his heart, which is not uncommon, actually, for quite a lot of people. When you've got that, obviously think about it, your heart's affecting your brain, but also because your heart is quite a more intricate thing anyway, whereas a tooth extraction, if you've had it done before, even if you're impaired in your functioning on other decisions, that if you've had it before, you know the process, so he already knew that. Yeah.
So when you ask the questions to assess capacity, if the person has capacity, do you ask them just once, or do you ask them again a little while later?
Good question. Yes, I asked them. It depends on how soon, Claudia, before the procedure. If I'm seeing them and the procedure's that day, then I won't ask them again. Mm-hmm. But I will always put in the notes that the consultants that are doing the operation, the surgeon, and also needs to be happy that the person has capacity. I won't then do another one that day, but I will make a note in the notes that they need to do it as well, and they need to feel comfortable with doing that. But I will put mine in there, and I'll detail exactly whether I think the person has or hasn't got capacity. But I'll try not to do it too many times. The reason for that is that it is unlikely that if someone, for example, someone's got a severe learning disability, they're not going to get a heart operation ever. You're never going to be able, whatever signs, pictures, symbols, diagrams you use, you're never going to be sure that they do or don't understand it. You're going to more likely than not realise they don't understand it. But if you think back to the example that I gave before, that was the first time I've ever had somebody who quite clearly lacked capacity. All she was on about was bingo. She didn't take in the severity of the situation at all, and yet, a few days post-op, she said, oh, you're the guy who told me I was going to die. But that just reminds you about how you need to phrase things with people, and you never know. Yes, people's capacity can fluctuate, obviously, and that's why it's always time, decision, and location specific. But it is something that people very often get wrong. One of the biggest problems that you'll find up and down the country is people will think that somebody can consent from another person. There are an awful lot of clinicians in all hospitals and in clinical settings that feel that somebody else can consent for someone else. And will also be anxious because they think, oh, I don't know if I've got this completely right, I'm not normally working with people with learning disabilities, so I don't know. And therefore think that they've lacked capacity and will say they haven't got capacity.
I think one of the problems we have is, people's confidence. At what level people, anybody can do a capacity assessment as long as they're in interchange with somebody else. But I think people think that it has to be a consultant psychiatrist or somebody like yourself who specialises, and yet, it might be that you've got a community nurse working out in the community, or that will have to make that assessment sometimes, and yet there's very little education really about what the 4 factors to make a capacity assessment are. And now we're finding, because I manage IMCA, the IMCA service impacting as well, on the boroughs, is that, they think IMCA's there to do a capacity assessment, or social workers will want to get involved in the capacity assessment, and this is one of the problems I think we've
Yeah, I think it is a problem. I think largely it's because people are frightened of the Act and don't actually understand that it's the most wonderful piece of legislation I think this country has passed ever. And I think the 5 key principles, all you've got to do is if you're with the 5, you're always safe. You always act within the law. But it is, you're right, it's about the confidence. Can you stand up in a court? I can. And that's not me saying I've always... some decisions that I've made, in hindsight, yeah. But I didn't have that information. You know, when you're stuck in A&E and you've got to make decisions and you've got quick time reality to make a decision and you don't have the blessed time of saying, right, we'll come back to that decision. Well, that's great if the person's dead. That's not really very helpful, is it? So you don't have time to do that always. Would I say that decisions... I would say that the correct decision at the time. In hindsight, have they always ended up being the best possible decision if we'd known everything? No. But at that time... And that's why you should always date, time, everything that you sign and print your name. It's really important because I've certainly come back, like you say, that when I've got other information about them, I'll come back and my decision might well have changed because I've now found out more information which alters it. Then I'll write that in the medical notes and I will say, further to that, disregard previous, this is what I've now found out, and I'll really highlight the information and I'll make sure I tell a number of colleagues and document who I've told as well. So I'll talk to the consultant, I'll talk to the senior nurse in charge on the ward as well, and some other key professionals that are their physios, speech therapists, whoever's really looking after that person, so people will know that there has now been a change because of what we found out. And if you don't do that, things go very wrong. But a lot of it is the fear factor, and to be fair, it's also because universities and those that train professionals are not doing their jobs. Quite simply, they're not telling people enough about the law. And also because we're getting people from European countries, for example, Spain, where the law is that in certain situations people can consent for someone else. And this law, this country does not permit that. And we do have that. And I'm looking at the GMC. You know exactly what I'm talking about. Because we've had this discussion before, and I've had this discussion with the GMC about this, and I'm not concerned. It's also the Nurse and Midwifery Council. Others have had this problem. That it is something where the laws are different. I think the entry for somebody coming into this country, and I know the GMC have recently said it's a Nurse and Midwifery Council as well, that people should be able to speak the language of the country that they're in. If I'm going to go and work in Germany as a clinician, I must be able to speak good enough German so that I can actually practice safely, and I understand the difference in the German laws that are pertaining to my specific area of work. And I think that's only right and proper. And I don't think that's a bad thing. I think it's an extremely safe thing, because I wouldn't want to be looked after by somebody who doesn't understand the laws of the country. They might be a very good clinician, but they don't understand what I'm saying to them, and nor do they actually understand all the laws, and that's where it becomes unsafe. But that's something that all regulatory bodies are on top of.
And I'm also encouraged to see that we've got in here about mentioning about the role of the IMCA as well, the independent capacity advocate. Because in what you've been talking about is allowed to use medical treatments, which they need to be involved in making a decision if they want somebody appropriate to consult about that. But also, you know, we have the change of accommodation decisions as well when they're being discharged. You know, there's also implications for safeguarding.
Absolutely. Yeah. I think the use of the IMCA is a very, very powerful thing to use. I think people misinterpret the use of the IMCA, and sometimes people do it if they don't like what family members are saying. That doesn't mean that the family members are actually not acting the best. So you have to have real evidence if you're going to basically say disregard their view and get an IMCA involved. I've had to do that a couple of times when I've questioned the views of the family like that. But in all honesty, what I've found is that the IMCAs work very, very quickly when we're saying, look, this is the situation, these are the decisions we need to make, we want to consult with you. What you can't do, by the way, for an IMCA, if anybody is still unclear, is it's against the law to ignore an IMCA, and you're not allowed to ignore them. What you are allowed to do is disagree, and a clinician, senior clinician, normally a medical consultant, can say they don't agree with, and this is why they're going to go ahead with this treatment, because it's in the person's clinical best interest, because the IMCA is not the medical person treating, but they're there to advocate for the person. But if you're not allowed to ignore them, but you can say that this is the decision, you don't agree with their view, but this is what you're going to do because the evidence demonstrates this.
And if we can just add that an INCA would never make recommendations,
No.
they'll only make points of consideration.
As a consultee and as trying to explore the thinking process behind it, you're right, they wouldn't, but I think sometimes people do misinterpret the role.
And yet what we're finding, I mean, in the results of the from the Department of Health about the uptake of the INCA service, we're finding and our practical experience on the ground is that there's still lots of serious medical treatment decisions being made without the role of an INCA, particularly decisions such as that of resuscitate, that haven't been seen as a serious medical treatment for some reason. So.
Yes, there are. And talking about DNARs, if you look at the sections 3, by the way, there's only 5 sections on the form, so it's really not hard for people to fill in. It's actually laziness not to do it, but also it's actually not lawful. Section 3 must be completed, and that's the bit which says, have you consulted the person or the relatives themselves? Now, it doesn't mean you have to, because obviously if somebody is quite clearly unable to do that, and somebody's often out of Mongolia or Australia, you're not going to do that, but you need to document something in there. But I think also it's looking at why is the decision being made, and I think things like Holby City do not help, because in there 95% of people come back from resuscitation, whereas in reality 95% of people do not, and the 5% that do come back with often smashed up bodies and live for a few hours later and are drugged to the hilt at that point. The ones that do come back are 25-year-olds with a very strong heart and constitution. Those are the sort of stats that people need to be aware of. Those aren't exact stats, but those are the kind of things that people really need to be aware of. I think people forget that because obviously the doctor's first duty is to do no harm. And if you're smashing somebody's body up by doing CPR, you are doing them harm. And if you know that it's going to be futile and they're going to live for maybe a matter of hours, but they're going to live assisted and on a hell of a lot of drugs, that's not a life. So it's a difficult one to weigh up.
Yeah, I think we'll have to finish in a minute or two. Was there one more question?
Good.
I was interested in this hospital, and I was wondering if there were some boundaries for using them with their students. You only mentioned the positive sides of it, so couldn't there be anything you would like to hide? And I mean, you say it's only a question of safety, but is it always safe? I mean.
Yeah, I mean, obviously, you're right, because it depends if somebody's caring for somebody and then they're not putting in the correct information. But I think you've got to kind of work that out. If somebody's putting something really bizarre in there, then you would be thinking, hang on a second. Either the patient themselves is not really au fait with what's going on for themselves, so it may be that they're mentally unwell, in which case they're probably not the best person at that point to fill it in. But you've always got to start with the premise that everybody has the best intentions for the person that they support, love and care for. But yes, you're right. People could, I've not come across it yet actually, but people could write things in there. It would not be very sensible of them to do that, but if it was something that was in there that was bizarre, I would hope that clinicians would pick it up and think, well, that's a bit of a strange thing, better just check that out. But the most important thing is that you talk to the person and their carers first, even if there's the passport there. The passport is really when there's nobody else around, or it's in addition to the care, and you'd be guided by both, but really it's important to speak to the person and their relatives and carers and supporters. But I haven't come across that, but you're right, it could happen, just with anything else, but it hasn't risen yet.
Right, I think we'd better finish now.
Just one more question.
Okay, just one more.
I'll keep it quick, I'll be a quick answer.
It's two very quick things. One is on the whole training of the law aspect. We've done lots of training with CAMS all across the country, particularly the community care, community network of community CAMS. And I know the NHS is so huge and vast, but certainly CAMS have sort of taken on board the kind of legal aspects. My colleague is a human capacity person I'm involved in contact, and we've done lots of different groups, and we're speaking at a conference coming up. And I don't know how that's come about, whether they're, because they see these issues, because it's come out in kind of conversation, and they realise this is something they don't know about. But certainly I just thought it was interesting to mention that they seem to be sort of aware of that kind of need and are sort of seeking out ways of meeting it. And the other thing was I was interested that, I mean, you're obviously doing a phenomenal job.
Well, I don't know. You'd have to ask other people.
Well, no, I mean, I think listening today, and I was just interested that obviously you're one person in a huge hospital, and yet it was a very receptive hospital. And I just wondered whether you'd been involved in any of their sort of public sector quality duty planning to see whether the size of your team could be increased. Are they seeing this as a kind of...
The size of the team? You're looking at the team?
I know. I mean, I got that. And I just wondered whether you have sort of that, whether you have a kind of voice up to the top, the very people who recognise...
Yes, I do. And a quick answer to that. We had a chap with Down syndrome who has diabetes, and the mention of the syndrome is important because having Down syndrome and having diabetes, two things don't go well together. He spent between 10 and 15 days every month with us. He hasn't been in for a year. That is an amazing achievement from the staff and myself. I blocked his discharge the last time he was in because it wasn't safe, because I hadn't got everything planned. Bed managers got excited, everybody got excited, and said, hang on, if this doesn't work out, have a go at me. But we know he comes in, fact not fiction, and he costs a lot. For himself, the quality of life is diminished if you're living in an acute hospital anyway. Plus the negative impact of diabetes. He was hypo, all over the place on his vital organs. That's not good. So I said, look, this is what we're going to do. So you can get excited, but this is the reality. And blocking his discharge, making sure that everything was in place safely for him, has meant he's been out for over a year. Now, that is an amazing amount of money cost saving, if you like, to the hospital. It's a huge quality of life gain for him because he's not hanging around with us, and he's very, very hard to get stable. So there's cases like that all the time, and I put the cases, I mean, very frequently I'll discharge people home 2, maybe 3 days before I would if they lived in residential care. Why? Because, no disrespect to any residential care colleague, they don't love them like family members do, and that's no disrespect to them. It's the reality. So I will do that. For example, guys who've got crackles on their chest and the base of the lungs have still got crackles, but I'll get them home because it's a better environment for them, and as long as the family are aware not to do too much in the next few days, and if they come back in and come straight to A&E, call me and we'll get it sorted out again, then they'll do that. But they tend not to come straight back in because they're happy to be out, and they'll listen to the guidance myself and the medical consultants will give them.
Right. Well, thank you so much, Jim. That was a terrific talk. Very illuminating, I'm sure everybody thought. If anybody would like Jim's slides, which we weren't able to show, can they send me an email? You should all have my email. It's the person, Dory Pilling, who you booked your place at the seminar with. So do send me an email if you'd like Jim's slides.
Oh, and can I make a plea as well? Could you all... I'm going to send Dory in. Literally, the evaluation is 3 questions. What you thought of the session, what was important about the session, how it's going to change your practice, and what other things you think you could have found out about. And I'll send it over to Dory and she'll circulate it. If you don't want to fill it in, that's fine, but it helps me in terms of my clinical audit trail, of my clinical teaching, which is being analysed by the clinical audit team now. And I've now, with you, I've probably spoken to over 350 staff this year in different bespoke sessions within the hospital and externally. Okay.
Thanks.